Hi there, I'm Dan. I'm a junior doctor and I am currently taking a little bit of a break from clinical medicine in the NHS. Medicine has given me some unbelievable experiences and there have been some really big challenges that I've had to overcome along the way.
Left my coat at work.
In this series of videos, I want to share some of those experiences, go back, relive them, and tell you how I felt and what I learned from them.
The last two videos are the very first jobs I've ever had as a junior doctor. Today we're talking about PICU, or Paediatric Intensive Care, down here in London at St George's. To start this video, we're going back to August of 2019. I just finished my F2 year and that was at Mansfield. Had a month off. I went on a great trip to Canada with my family and then refreshed, came back to London. I locumed for a bit, but I'm kind of going to skip over that. I have done a video about locuming. It wasn't a great time and I only did that for about 6 weeks. And then very quickly I fell into a job at the Paediatric Intensive Care Unit at St George's. And I basically got that job just because a friend was working there. I didn't really know what to do and I'd liked peds in my F2 years. However, looking back, I'm so grateful that I did take that job. It has taught me so much and it's probably the job that's influenced me the most over my career as a junior doctor. I think it's always really hard when you're looking back to actually appreciate just how much you knew or how much you didn't know. And I found that when reflecting on this job is that actually I knew so little at this point and I take for granted all of the experiences and learning that I've done since then. And this was probably the job where I went from being like a standard junior doctor to one that was actually fairly confident or competent at a number of things and had a handle on the basics of physiology, pharmacology, the basic pathology, and actually that was through seeing some very sick children and understanding what was going on. It was a very specialist environment that I was getting myself into and actually knew very little about the machines, about ventilation, about any of the drugs. And so I was learning so much on my first couple of weeks. There was also the pathology that I'd not seen before. Although I'd done some paediatrics in the past, when our patients at Mansfield had got really sick, we'd ship them out to Sheffield. And so I didn't actually see them when they were extremely unwell. Some of them had pathologies that I'd never really experienced, like paediatric cancer or neurosurgical issues. And so not only was there the whole ITU thing to get my head around, but this whole caseload of patients that I had never seen before. There were obviously other pathologies as well, but I think the one that is probably notable to talk about is the oncology. The PICU at St George's supports Marsden, and as a result, when their patients became extremely unwell, they would come to our PICU. Often these patients were having bone marrow transplants or chemotherapies, and they were probably the sickest patient cohort that I've ever seen. Not every paediatric cancer patient has a journey which includes a trip to PICU, and we saw the worst sort of a very, sad cohort. But yeah, they were extremely unwell, had very prolonged stays. Not all of them, unfortunately, made it, obviously, and they were a group of patients that resonated, that just left an impression on me. And I think that was a large part of where I did most of my learning on the unit, was looking after those patients particularly. So I think the easiest way to explain what went on the unit and the whole job itself was to actually go through a day. So we'd turn up at the unit at about 8:30, we'd get the handover from the night team, and then we'd divvy out the patients. Often we'd see 2 to 3 patients each. The junior doctors would then go around and see each patient individually and do a full A to E assessment. So in medicine, when there's a new situation, when something's drastically changed with a patient's sort of clinical presentation, you always fall back on this thing called the A to E approach. A, B, C, D, E. That would be airway, breathing, circulation, disability, and then everything else. It is ranked in what would kill you first, but this is also a fail-safe way to make sure you're not missing anything, and we would essentially do that every single morning. So we'd do a full A to E assessment, and I think the easiest way for me to try and teach you how in-depth they were is to probably go through one. This is something that I picked out of my portfolio. It's completely anonymized, and it's a patient that's come back from theatre, but it kind of just gives you an idea of just how much detail. There is so much information. They've come back from theatre. They have a nasal cuffed endotracheal tube, size 4, 16 centimeters at the nostril. Endotracheal means that it's within the trachea or the windpipe. Nasal means that it's in the nose. It's cuffed, which means it's got a cuff around the bottom of it, which you can blow up with a syringe. It's 16 centimeters at the nostril, so we keep a measure of that so we can see if a tube has moved. Sometimes if there's a breathing issue or they're ventilating differently, we check where is it at the nostril and is that where we've documented it? Has it gone in or has it come out a bit? And is that why they're having a new breathing issue? CXR reviewed, that means chest x-ray, and that's checking where the tube is. So it should be above the carina, which is where the windpipe bifurcates. The position is adequate with good bilateral air entry, that means that it's ventilating both the right and left lung, and no bradycardias. Sometimes if that's too far down, it can stimulate the vagal nerve and lead your heart rate to drop, so that may be a sign that the tube is too far in. Next is BiPAP, so biphasic inspiratory positive airway pressure, and that's 20/6. So this is the machine itself ventilating the patient, so pushing a pressure of 20 in. As the patient's lungs breathe out, we also keep a small pressure of 6 there, and that's called the PEEP, or the positive end expiratory pressure. That's the rest rate of 32, they've got good tidal volumes. The FiO2 is the amount of inspired oxygen, so they're in a bit more oxygen, because room air is 21%. Blood gases were reviewed, so we're looking now at the blood itself and seeing how much the oxygen and the carbon dioxide is, and we can tell from that how well or how badly a patient is being ventilated, and that's got adequate gas exchange, so that's a good thing. Initially supported by adrenaline and noradrenaline, so these are two drugs that we call inotropes. They're very strong medications, and they lead to vasoconstriction, so the arteries then constrict, become smaller, and that increases your blood pressure. Their heart rate was high at 175. Their mean arterial blood pressure was around 55 to 60. So despite being on those supportive treatments, they still don't have the best blood pressure in the world. So that's probably a bit of a worrying sign. They needed 20 mils per kilo of fluid bolus, so that's a fair bolus for a pediatric patient. It's basically like giving a patient a drink, but directly into their veins. So it expands the amount of fluid within their circulatory system. And we can see that that's actually led to a reduced heart rate, and their MAPs have improved, so their blood pressure's come up. So that's a really good outcome from that bolus. As a result, the adrenaline was weaned. And then going into disability, normally this would be their pain or their alertness, but in pediatric intensive care or in other intensive cares, we also put all the sedation in here. So they're on morphine and midazolam, morphine for analgesia or pain relief, and then midazolam to keep them sedated. We also checked the blood sugar in the D, and that was normal. And the neurology we normally assess, but actually you can't do that when a patient's so heavily sedated. Everything else, so their abdomen is soft. They've got a nasogastric tube on free drainage. So that's a tube going in through the nostril down into the stomach, and that allows any pressure to be relieved by drainage out the top of the stomach. They're afebrile, so they don't have a fever. They're on IV colomoxiclav, which is an intravenous broad spectrum antibiotic. Their potassium is quite high, 6.6, and that needed treatment with calcium gluconate. So that supports the heart when you have a very high potassium, which can lead to arrhythmias and actually be quite a bad thing. They also got some sodium bicarbonate, that was probably to help with the potassium as well. And probably the worst sign of this all is that despite being on all those things, noradrenaline, adrenaline, they still don't have a urine output. And that means that we're not perfusing the kidneys very well, and they're not actually producing any urine. So that's actually not a very good sign at all. That's probably why their potassium's gone up. This is a very sick patient. We didn't always have sick patients like this, but infrequently we would have a very sick patient, and they would take up a lot of resources, sometimes need multiple organs to be supported. And I hope that gives you just a bit of an insight into just how complicated these patients were. So like I said, so you go away, you do that. As you were doing that, the consultants would also go around, they'd review the patients, and then you all meet in the ward room at 11 o'clock. It wasn't like a typical ward round where you go around with a computer on wheels or a cow. Actually, what we'd do is we'd have a meeting. The nurses would come in one by one and they'd report about their patient. The doctor would then hand over what they assessed. We'd also have all the results on the board. We'd also review all the imaging, and then with the consultants, with all the junior doctors, with the nursing staff, and then with any other consultants that are looking after the patient. So maybe a surgeon, maybe an oncologist, maybe the infectious diseases team. Together, we'd all come up with a management plan. So when I first started, I was then having to do that handover that I've just talked you through, but then give that to maybe like 20 other people within this room on a really busy day. So that was pretty nerve-wracking. Obviously, some of these patients had been here a long time, so you had to understand what had gone on in their history and then piece together their whole journey whilst also presenting how they were looking today. And that was a true art. I was very bad at that at the start, but I learned so much. My handover skills, my communication as a medic is so much better from hearing other people talk about it, but also having to practice it myself. And then once we'd done that, that would take a few hours, especially if it was a busy ward round, if there was some complicated patients. Then we'd go off, do our ward jobs and have some admissions, have some discharges, chase scans, things like that. And then at 4 o'clock, we'd also hand over to the evening team, and that would be that. So overall, it was a brilliant job. I was there for 6 months on a contract, then I locumed and supported the unit for another 6 months. I went to the Nightingale in between, and that's going to be the next job that we talk about, so make sure you don't miss that one. Obviously, it's quite a unique job. A lot of people never actually work in a PICU. I'd highly recommend it. I really enjoyed working on that unit. Everyone was very good clinicians. The consultants were contactable at any point. Highly recommend the job. Really enjoyed it. I think the obvious thing to talk about is the fact that not all patients survived and the difficulties that you faced. I was probably a bit underprepared for that when I went into the job. As I said, I kind of took the job on a whim, and I'd had some experiences with end-of-life care, especially in my geriatric cohort, but this was where I saw probably the sickest patients that I've ever seen. We had some patients that had very long stays, got to know their families, and they still didn't have a favourable outcome. And I guess things that helped me with that were, firstly, if I was there and involved in a very sad or tragic case, I was able to influence the outcome. And although the outcome probably wouldn't be influenced greatly and was likely to still be sad, I could make that process slightly better. And if I wasn't there, then I couldn't influence that. And that was one of the sort of things I understood and gave me a bit of comfort in the face of really some very tragic cases. The second thing that I would say is, and I kind of touched on it in my Jerry's job, but I really got an appreciation for it in this job, was you really care about your work. And I found that in the pandemic as well, but the little things became so important, and also found that when I was at work, there was very little that you could say would be a better use of your time. And that was shared amongst the staff. If you were at work, you were there to work, and the care that I witnessed was excellent. I learnt what good care looks like and what we should be striving for, and it was a really refreshing job. I think it really gave me a lot of hope. I've talked about how big the ward round was. At points there may have been 5, 6, 7, 8 consultants in that room, talking about one 2-year-old or 4-year-old. And we may be in contact with other specialties at other hospitals, sometimes internationally, and it was an incredible pool of resources that we had access to. And that, I think, was something I needed to see. Sometimes in the NHS it's difficult. And actually that was an example of a unit where the care was excellent, and sure, there were still difficult days and it was hard work and we stayed late and all the other stuff, but the important stuff we were getting right, and it was very well done. And yeah, and I thought that was just so cool. I would sometimes just be like, am I here? And I'd look around the room and there would be incredible clinicians, probably with hundreds of years of combined experience, and they were all talking about one 2-year-old that we'll never know, and most of those 2-year-olds did very well, and we had some excellent outcomes. I think the other thing is you always remember the difficult cases. So actually we treated thousands of patients, and actually they had mostly very good outcomes, but you don't remember those. You remember the difficult ones or the tragic ones. I just wanted to touch on that because I think it would be disingenuous to say that it was a great job and that I learned loads about critical care. I did, but it was challenging, and but I learned loads in that front as well. Really enjoyed it. Thought the team was fantastic. I've done some paediatrics since, so sometimes have to refer my patients up to PICU, and they're a really good team. So yeah, I hope that was interesting. I hope I haven't rambled too much, but if you did enjoy that, please make sure you subscribe. We're going to be talking about a few more jobs. The next one is going to be the Nightingale, which is the pop-up ITU that we had set up in East London when we didn't really know very much about COVID. I volunteered to work there after my PICU contract ended, so make sure you don't miss that one. That's probably going to be one of my best videos on the channel yet. And if you did enjoy that, and you know anyone that's thinking about applying to medicine or anyone that's in medicine, share them this video. And if you're a doctor, do a PICU job. If you're a nurse, do a PICU job. And I'll see you in the next video. Cheers. Bye.